Muy bien, la siguiente cirugía va a ser a cargo del doctor Federico Fossati, una enucleación bipolar de próstata. Federico, a pesar de su corta edad, es un referente en esta técnica en el país. Trabaja en Urología del Oeste en Trenquelauquen, acá en la provincia de Buenos Aires. Va a estar moderado, por un lado, hablando tanto de la Swiss Army por Thomas Herrmann, que es uno de los grandes referentes de la enucleación bipolar mundiales, y por Mohammed Omar, quien es también otro gran referente de Egipto. A nivel local tenemos a Federico Minuzzi, que es urólogo de la Fundación Neurológica de Córdoba, a Benjamín Tumburus, endorólogo y experto también en enucleación en Tucumán, Rodrigo Melogno, desde Uruguay, jefe de urología en Comero, en Uruguay. Y vamos a implementar por primera vez la moderación y la participación de instrumentadoras. Entonces tenemos cambiada en la cirugía a la licenciada Paola Silva, que es nuestra instrumentadora, una de las más grandes instrumentadoras y que más sabe de endourología en general. Va a estar cambiada y va a estar participando. Y tenemos acá en el piso a Liliana Gladys Sanchez, que es instrumentadora con vasta experiencia también en enucleación. Me parece que esto es un nuevo abordaje que estamos teniendo en Urovivo después de tantos años para incluir la perspectiva de alguien más del equipo de salud, que es fundamental, porque nosotros vemos toda una parte de lo que es la cirugía y ellas están ahí y sin ellas no podríamos hacer nada. Así que les agradezco especialmente a las dos. Vamos a presentar el caso clínico. Doctor Alves, el residente de urología, va a presentar.
Bueno, el caso se trata de un masculino de 83 años de edad. Tiene un índice de masa corporal de 21 y como antecedentes personales se encontraba en tratamiento con tamsuloxina y dutasteride hace más de 20 años por hiperplasia prostática. Y en consultorio nos refiere empeoramiento de los síntomas, nocturia por 5 y chorro débil. El IPCS score es de 22, severo, con una calidad de vida de 5, descontento. El PSA es de 0.26. Esta es la uroflujometría. El flujo máximo es de 9.4, el flujo promedio de 3.8 con un volumen total de 163. La ecografía transrectal nos arroja un volumen prostático de 67 gramos y la ecabdominal con un residuo vesical un residuo premiccional de 231 con un residuo postmiccional de 114 mililitros. La función renal es conservada, el urocultivo es negativo y el examen dígito rectal no es sospechoso.
Doctor Fossati, ¿nos escucha?
Muchas gracias por la presentación. Me acompañan acá en quirófano también Herrmann Ramírez Bosniuk, Mariano Orellana. Somos todos hijos de esta gran escuela urológica que es el Hospital de Clínicas. Estamos muy contentos de poder estar acá participando del Urovivo, mostrando nuestra técnica de enucleación prostática con energía bipolar. Estamos con algunos problemitas técnicos con la cámara, así que en minutos nada más vamos a empezar. Empezamos con esta técnica nosotros hace más o menos 3 años, buscando una alternativa para tratar de ofrecerle a nuestros pacientes el mejor tratamiento posible dentro de nuestras posibilidades, un tratamiento costo efectivo, teniendo en cuenta que ejercemos en el interior de nuestro país, en un centro de mediano volumen. Se nos hace un poco difícil acceder a un láser de alta potencia, pero bueno, nos metimos en el mundo de la enucleación con energía bipolar. La verdad que nos ha dado muchas satisfacciones y más importante que eso, le ha dado muchas satisfacciones a nuestros pacientes. Estamos muy contentos con la técnica y bueno, esperemos hoy poder mostrarla y poder transmitirles nuestro entusiasmo.
Sí.
Por ahora no vamos a poder hacerlo, pero les prometo que sí.
Si quieren podemos hablar un poquito, la licenciada Gladys, a ver si algunos detalles a tener en cuenta antes de empezar.
Hola.
Bueno,
buenas tardes.
Primero hablemos un poco del paciente. Es un paciente que, si vieron la presentación, se está operando un poco tarde. Creo que estarán de acuerdo. pero es algo que vemos muy frecuentemente en nuestra práctica, el tratamiento médico excesivo, tal vez fallas en los pacientes, tal vez fallas nuestras, pero bueno, vemos que muchos de nuestros pacientes están operando ya con un daño vesical que después influye en el postoperatorio. Este paciente ya tiene una vejiga de lucha, la pudimos ver cuando entramos con el citoscopio, 20 años con tratamiento médico, síntomas severos. Lo primero que podría decir es tratar de operar a los pacientes en el momento justo, ¿sí? Porque eso va a influir muchísimo en el postoperatorio, qué vejiga tiene el paciente cuando se somete a la cirugía. Nosotros cuando comenzamos con esta técnica, obviamente, hacíamos RTU, resecciones transuretrales, con bipolar, y lo bueno que tiene esta técnica es que nos permite empezar a hacer la curva mientras hacemos las resecciones. Nosotros enucleábamos medio lóbulo, después hacíamos una RTU, después enucleábamos un lóbulo entero, seguíamos con RTU, y así nos fuimos haciendo nuestra curva hasta que pudimos enuclear una próstata entera. Actualmente estamos haciendo la técnica trilobar, o sea, en bloque, no trilobar. Pero bueno, por ahí, para empezar, tal vez puede ser un poco más fácil empezar por lóbulos, hacer técnica trilobar o bilobar. Ahora vamos a tratar de mostrar nuestra técnica de enucleación en bloque.
La tenemos a Gladys Sánchez acá, la licenciada, para hablar, si querés, un poco de ese aspecto previamente, ¿no? ¿Querés hacer algún comentario?
Bueno, ahí vemos. Hola, Paola, buenas tardes. Buenas tardes, doctor Fossati.
Buenas tardes.
Ahí vemos como el equipo que está utilizando, que es un resectoscopio camisa 26. Supongo que está usando el doctor una ansa de resección de Herrmann. Ahí está. Es esa.
Sí.
Que tiene una particularidad, que es que reseca muy bien el plano de la próstata, el plano de clivaje, encuentra muy bien el plano de clivaje. Ahí tiene que setear el doctor, no sé, setea el bipolar, creo, si mal no recuerdo, en uno en corte y 2 de coagulación. ¿Es así?
Correcto, usamos bastante poca energía, ya van a ver, tratamos de hacer la técnica con maniobras romas, ayudándonos con la punta de la camisa y con el mismo electrodo de nucleación. Primero, como les decía, hacemos una cistoscopía, vemos esta vejiga de lucha, celdas trabéculas, algún divertículo vimos por ahí. Y bueno, vamos a empezar con la cirugía, no me quiero exceder en el tiempo, ya vamos a tener tiempo para hablar. Esta próstata de 67 gramos por ecografía. Identificamos el esfínter, que lo tenemos acá atrás. Y comenzamos con la marcación de la mucosa. Van a ver bastantes similitudes con algunas técnicas que hemos visto de nucleación con láser. La verdad que es lo que más tenemos al alcance para ver y para reproducir. Hay mucha más bibliografía sobre nucleación con láser que bipolar. Pero van a ver que la técnica tiene bastantes similitudes. Buscamos el plano. El mejor lugar para encontrar el plano es en hora 5 en el lóbulo izquierdo y hora 7 en el lóbulo derecho. Así que ahí lo buscamos de los dos lados. Ahí vemos algunas calcificaciones que nos indican que estamos en el plano correcto, entre la zona transicional y la zona periférica. A veces marcamos toda la mucosa de inicio, a veces vamos primero buscando el plano y después marcando la mucosa. Ahí vemos cómo se va delimitando el plano del lóbulo izquierdo. Y ahora vamos a hacer lo mismo en el lóbulo derecho.
Hola, Federico. Benjamín Tumburus. Te hago una pregunta. ¿Hacés liberación apical precoz?
Sí, siempre tratamos de realizarla. Empezamos por la cara posterior, como les decía, que es el mejor lugar para encontrar el plano, pero tratamos de no progresar demasiado hasta no liberar también el pico en la cara anterior. Ahí, como les decía,
una pregunta de... Disculpa.
Estamos en hora 7.
Una pregunta.
Plano.
¿No haces,
Sí.
no haces una atento para preservar la eyaculación antegrad?
La verdad que no,
pero
todavía no estamos familiarizados con la técnica de preservación de eyaculación. La verdad que priorizamos hacer una buena desobstrucción, pero sí, sabemos que
Sí.
hay alguna evidencia en que preservar justamente esta zona que estoy cortando ahora puede tener algún beneficio, aunque obviamente no garantiza la preservación de la eyaculación. Pero no la hacemos habitualmente. Sobre todo un paciente...
En general, no pienso que es un problema grande por los pacientes. Solo algunos pacientes están bastante preocupados por eso, pero tienes un counseling por el orgasmo fue el mismo after surgery, then they don't mind. So sorry, my Spanish is so bad. I have to switch to English. But you're doing it wonderful. I just wanted to comment. You're doing it wonderful. Yeah, and I think that it's exactly there are many ways lead to Rome, and you of course find the lateral side. You find the easiest and nicest, as you did, nicely showed.
So Dr. Federico, very nice start, really, I like it. So my question is, which size of prostate do you prefer in doing bipolar enucleation? Like usually every platform and every energy have a favorable size. So for me, like when I starting or when I recruit a patient for doing a live surgery, I would prefer over 100 grams. Like the plane is better with the bipolar in larger size prostate. So do you agree with this, or do you prefer the smaller one?
I prefer 80 is always nice. 80 is not too small and not too big, because I have the perception, I had it 3 weeks ago, I was presented a 100-gram gland, and then I had 186 gram of resection weight. So that also could happen. So this is why if I do live surgery, I love 80 to 100, because then it is most likely not 250. Yeah, and that is what you do not want to show in live surgery. We had these cases this year in Salzburg with Professor Luzuardi. We wanted to tackle big glands, and we had 180, 120, and 140, which one turned out to be 230. So that is something which is, let's say, you can do it at home nicely, but on live surgery, it becomes a little bothersome.
So we have to admit something for the AAB community, that we have an advantage when doing surgery with the bipolar, that we are the most hemostatic. So this is one of the points, that we don't feel having pleaders with a large prostate in a live surgery, like holmium and tholium are going to have the same feel, because bipolar is the best hemostatic. This is the least thing that you are afraid of, but you are afraid more about the advance of the transitional zone with the peripheral and the capsule. And this usually is happening when you're having a higher prostate, a history of chronic prostatitis, or anything that is going to have more and more fibrous tissue in the gland. But if we have a less adherent transitional zone, so you could run smoothly and safely, and you could save time. Even you could give it an OR time comparable or more, sometimes it's going to be less than doing laser. So I see him, he's going so fast. He went from one loop to the other side, running very, very smoothly and nicely. very hemostatic. Never you are going to find any bleeders. And also the amount of energy that we are dispersing as a capsule in the bipolar, if we are using a minimal pushes, this is not a power. This is a mechanical movement that going to make the trauma to the capsule less. And we know that after surgery, the mucosa from the bladder and from the urethra are going to creep to cover the capsule. And until this happens, the patient is having a dysuria. So if we are delivering the little amount of energy as just much as needed to stop a bleeder, and we are just inoculating the gland, as we do with our fingers in open surgery, is going to have a less trauma to the capsule, and maybe in the future, when we want to study to compare the dysuria and the amount of time that the capsule takes until it is healed and having a mucosa to cover its surface. And also, sometimes if someone went to the fossa after surgery by 2 to 4 weeks to do something else, he may find what we call regeneration nodules. This is a site of a trauma that have a lot of power have been delivered to this site. And this is a secondary healing, this is not the primary intention healing. So what I'm saying is bipolar may have a faster and less energy delivered to the capsule that is sometimes maybe having a less dysuria post-operatively.
I agree, absolutely agree, especially if you are wise, as you say, and not doing coagulations all the time. But so I always say everybody optimizes its setting according to the clinical results received. So we only have, I would say, center techniques. There's no comparison with the centers. So therefore, everybody does what produces the best results. And I would agree that you have, at least in my hands, I do all three techniques. I don't see a big difference. And I always use bipolar in patients with compromised bleeding disorders or medical like that. And what I especially like, what our surgeon does at the moment, is that he perfectly aligns the surface of the probe to the position where he is operating at the capsule. This is, I always say, scratching with a fingernail. This looks so nice. And if you expose the convex lower surface to the capsule so nice, you have a very nice and equal thermal spreading of the energy, which exactly produces what you said. You have, you don't need too much energy to perform a nice hemostasis. And my feeling is that, as you say, in light surgery, always the bipolar is the one with the least bleeding, 100%. You're doing it very nicely.
Yeah, he's running fast, really, I like it. And he's using your invention, your loop. So, very nice. And also, other things I have noticed, like, when you look to the fossa after bipolar and after laser, sometimes I find a difference in some places where I find it have a cavity below the bladder neck in the bipolar, and this means that you got the adenoma from its base. While sometimes in laser, I feel like you did make a less complete enucleation, because you know when you're using the laser setting, every movement is with blah 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 blah, it's power every time, and this is keeping what you leave as a white tissue. So sometimes you are leaving something is white, but this is not the capsule. It is a part of the adenoma attached to the capsule. In bipolar, mostly you can't go like this. Mostly you are adherent to the capsule most of the time. You are crawling with your belly over the capsule. So it's mandatory that you are enucleating the adenoma in everywhere, even at the bladder neck, even at the most deep part below the bladder neck. This is something that I feel the fossa from the bipolar little bit is bigger and more anatomical.
I think what I think we see it here. He's dancing around the lobe very nicely and always trying to loosen it where it's still attached. I like that. And I especially like this, if you do this on the bladder neck, if you come, a dorsal part of the bladder neck, if you come from the sides, and I would fully agree that this is easier with a mechanical probe than with a laser probe, because the laser probe is shooting straight. And if you do the mechanical, always goes a little bit like this because it has a curved surface below, I would say I would agree that is an advantage of if you use probes like this, we have a dedicated angle like this, so it's easier to come from the side.
Also, I like to show the surgeons that we are not doing mechanical bushes that is a bushes. It's really is a small, very, very minimal movement that doesn't leave you to say that bipolar is mechanical. This is not what you think about mechanical. I'm just moving in the right plane. Like it's small, minimal bushes. This is something that is not going to harm the capsule. You see no perforation so far now. And same time, this is not compressing over the sphincter and we are not destroying it by the mechanical movement. We are just running or circumventing the transitional zone in the right place, and such movement is not going to injure the sphincter by any way.
Yeah. So in the beginning, we had the story of anatomic enucleation like a blunt enucleation, and the hypomochlion was always the urethra. And the idea of this probe was that it transfers the mechanical push by the sheath towards a telescopic push, which doesn't inflict the hypomochlion anymore. And that is what he can nicely see. So all preparations, of course, he's holding up the space with a sheath, otherwise he would have no space. So you need to advance the sheath towards, but then you do all the preparations like this with the telescopic bushes, and this makes it a very atraumatic approach, 100%. So another face popped out on the right, a gentleman with a blue shirt. So what is your comment about that?
Hi, how are you, Thomas?
How are you?
I am Rodrigo Melogno from Uruguay.
Very good.
It's nice to be here.
So same here. You use also this probe? Do you also do a bipolar enucleation with this probe or with a different probe? There are many more probes than on the market.
I perform bipolar enucleation with the Storz loop, the Herrmann loop.
Oh, very good. No, thank you. Thank you. Thanks to thoughts. Except that I invented it, that's the only thing I have from it, that people know that I have been part of it. But other than that, I have no financial interest in it. So
No,
I'm a caritative man, you know, I doing things for good.
No, it's a really nice tool for perform this kind of surgeries, right? And you cut, you vaporize, you can move and make some blunt dissection. It's a really strong loop. I really like work with that.
I would add something. I think Dr. Herrmann was very smart to find the right angle that the loop needs to do the enucleation. So I think the most unique here is the angle of the loop. He discovered how your finger is like during enucleation, so he made the loop as your finger exactly doing enucleation. And this was a point that everybody is trying to do enucleation with other loops is trying to imitate Dr. Herrmann loop in the angle. So one thing is the angle, but the other issue with the Storz loops that they having the double stem and the blade that sometimes is may come in your vision and also may make a current that may make injury if you are not aware where is the second receptacle blade in. And also the size of the loop is a little bit like taking a lot of the screen, so you are not very, very comfortable with seeing everything behind the loop. Like the loop is having your center of vision. This is the only thing that if the loop is slimmer, maybe giving you a better field of vision to see the capsule behind, but it's magnificent. It is the start of in bipolar to have this angle, and I think this is the reason that bipolar enucleation is running now, because of this angle.
I agree. You can do intuitive preparations with it. So you don't worry about the right angle because it's already there. So I think that's a real charm of the engineering here. And of course, we tried several angles before finding the right one. And that was the one and the shape of the probe. And by the way, the size of the probe. So it's all, that is 1 out of, I think, 30 what you see here.
I hope
there's another
we...
probe, interestingly, there's another probe, other version we didn't use in the end, which can be seen on the Journal of Endourology. That was a slightly different probe, video urology from Journal of Endourology. There's a video we made in the beginning with a slightly different probe. That was also nice, but we switched in the end to this one because it's really the scratching of a fingernail imitated here.
And guess what? This electrode is very strong. Like I may resterilize, I may use it like 20 cases until it goes outside service. So it is very, very inexpensive, and even it is less expensive than doing resection. Like I could use the lobe for 20 cases, while resection you are losing 1 lobe per case. So it's giving something that is very, very nice. So my question to Dr. Herrmann, do you think that we could have benefit from using the 22 French? Like I like the idea to use a smaller scoop inside the urethra during running, circumventing the adenoma. So what do you think about the 22? Because I like it. I'm waiting that I find it in Egypt and try to use it.
Yeah, I also like the idea, but the point is with smaller sheath and we have the MELAB around. I think we need a complete setting of everything goes through one. That is what I would expect for improvement. I did only 26 French since I'm doing this since, first of all, as you know, I described DULEP, and the idea of what you said, the inexpensiveness, was exactly what I had in mind. So people said at that time, so why are you now switching to bipolar? You have your stake in TULEP. And I said, the point is not if I have a stake in TULEP. I said it today also on LinkedIn, I said, if we consider that enucleation is the best, what we can do to our patients for deobstruction, we need to provide it to everyone. And you need to have it as inexpensive as possible, because this is clearly better than TURP and open prostatectomy. I think the morbidity of endoscopic enucleation is so significantly different that we need to provide it for everyone, basically. And that was the idea. And I'm very happy that they still have it as a reusable probe, because that is part of the, I would say, deal in doing bipolar enucleation. Yeah.
And I think it's perfect for fellows and for residents, because with a really small amount of money, you can have all the things that you need to perform an endourology approach for benign prostatic hyperplasia. I think that is very, very helpful for all of one. Mostly if you have a resident in your team.
Actually, also we have a benefit that in my career I started doing TURB while I am using irrigation for 1 or 2 days, and then I went to AAB and still have 1 to 2 days. I didn't get smart and brave to do just no irrigation and 6 hours caster removal, except when I adopted bipolar enucleation. Like now I could say to my patients that the caster is going to stay as much as you have regional anesthesia, and when the spinal or regional anesthesia is out of your body, I'm going to remove the caster. I'm going to let you go home in the same day after 6 hours of surgery. I'm going to advise you just only don't have to make any hard movement. Don't lift something which is heavy. Don't do trying to have a constipation or something like this. This is the only thing that I'm afraid after doing bipolar enucleation, but I am very, very satisfied to remove the caster after 6 hours, and also not using an irrigation in the first 6 hours. I leave the patient without any irrigation, and this is something maybe important in places with less experienced nurses that are aware about using irrigation after the surgery. So now I'm not obligated to have irrigation running the tubes. The patient just have to drink and stay 6 hours until he have devoid from the anesthesia, and then remove the caster and leave the hospital of 6 hours, which is, I think, something ambulatory surgery centers would like to have, and this is going to make AAB more consistently as a less invasive surgery indeed.
Mohammed, that is fantastic. And please, let's put it into a paper. And I know a journal who would love
I'm working
to read
on
it.
this. So this, to be
Very
honest,
good.
I'm
Please
really working on this.
Please send it to me. I'll be interested in that. So we've just seen entering of the bladder neck, which has been doing just at that stage. And do you always do it like this, or do you sometimes do it on purpose earlier? Or is this your approach of keeping it as long closed as possible?
If it is large adenoma, I would prefer to do it from the start.
Okay.
So sometimes I go and get the adenoma. This is a good trick to say, like, when you have a difficult plane, I think 12 o'clock is the best way to get the adenoma from its better place. Like, we are trying to get the adenoma from its real place. You don't want to miss out from the adenoma if you are having a difficulty to find the plane. So as your finger did in the past doing open prostatectomy, your scope is going to do when you are doing enucleation. Go at 12 o'clock, and I'm sure in the bigger adenoma, you are going to have the right place immediately. And we have to say that here, he is doing try to not elevate, he is going to try to freeze the loop from the bladder neck. In this stage, it can't be only mechanical. Like, you have to cut the mucosa that is covering the bladder, that is going to cover also the prostate at this place. While if he went to this step, he is going to, the loop fall down, and then he is going to run fastly.
So the question to the surgeon. So is this your regular approach? You always try to keep it as long as possible closed so that you have a lower need for irrigation? Or what is your approach?
Sí, tratamos de dejar la mucosa de la vejiga preservada hasta el último momento para tener una mejor irrigación y mejor visión. Hacemos primero los lóbulos laterales. Cuando nos queda la parte más proximal del lóbulo medio, ahí entramos a la vejiga para poder acercarnos al lóbulo medio de lateral a medial. Ahí vemos cómo ya se empieza a evidenciar el cuello de la vejiga.
El lobo medial, sí.
I hate to say this, but we never have a problem with the irrigation during bipolar. Like, I think that problem with the irrigation is usually more with the laser. Like, when I finish doing enucleation, I empty the bladder and make it empty completely. And then I'm going again to see if there is any bleed I'm going to cauterize. So the issue about that we fear from the bleeding, or if I need to have a more irrigation, this is something I think bipolar solved this issue, because usually you're having a marvelous hemostasis. I see the video now, it's live surgery, and it's very fantastic. So it's always clean, there is no hematuria. He catches the bleeder before the bleeder think about the bleeding.
Yeah. Me gusta mucho cómo lo has preparado el bladder neck. Por eso, from the side, this looks so nice because you're peeling it off, and this is the way to remove retrotrigonal lobes very safely with regard to the perforations of the bladder neck. That's very nice to see. Congrats.
Ahí me va a colaborar un poquito Herrmann del lado del lóbulo derecho. Correcto, tratamos de ir abarcándolo desde los laterales. Como veíamos, tiene un lóbulo medio que se introduce un poco en el piso de la vejiga. Así que es la zona que es más propensa a que tengamos alguna perforación. Por lo tanto, acá vamos muy cautelosos. La verdad que tiene un plano bastante favorable esta próstata. Lo que se dice una próstata madura, lo que decíamos al principio, un paciente que se opera tarde, pero bueno, tiene estas ventajas también, que son las próstatas que tienen el plano más dibujado, lo mismo que experimentamos en la cirugía abierta, ¿no? Mientras más grande la próstata, mientras más evolucionada es su hiperplasia, mejor se encuentra el plano de enucleación. Vemos cómo usamos la menor cantidad de energía posible, usamos muchas maniobras Roma, pero tratamos de hacer maniobras circunferenciales, tratar de empujar lo menos posible. Si bien liberamos el ápice como primer medida, tratamos de empujar lo menos posible y hacer maniobras circunferenciales, y usamos bastante más la coagulación que el corte. Hacemos pequeños cortes cuando aparecen esas riendas, esas adherencias, y después usamos más que nada la coagulación, que en la energía bipolar es muy efectiva, muy certera. Creemos que esa es una ventaja por sobre la enucleación con láser, por más que los trabajos dicen que la enucleación con láser tiene menos sangrado. La realidad es que la hemostasia puntual de vasos grandes o medianos es bastante más efectiva con el bipolar. De hecho, vemos que muchos cirujanos que hacen enucleación con láser finalmente hacen hemostasia de la cápsula con energía bipolar. Sabemos cómo Herrmann ya está liberando su lado derecho. Tenemos la próstata agarrada de su lóbulo medio.
Federico, excelente cirugía. Yo hago exactamente lo mismo, una liberación apical precoz y una enucleación en bloque. Quería preguntarte qué incidencia de incontinencia transitoria de esfuerzo tenés después de esta cirugía.
Mira, tenemos los números hechos de nuestros primeros 100 casos. Habría que rever después si la curva de aprendizaje nos mejora esto, pero nosotros le preguntamos a todos nuestros pacientes si tienen incontinencia la semana posterior a la cirugía. Le preguntamos a las 2 semanas, a las 3 semanas, al mes. Y incontinencia es una gota de orina, ya sea de esfuerzo, ya sea de urgencia. Y tenemos en la primera semana una tasa de incontinencia del 30%, lo cual es significativo. Eso hay que comentárselo a todos los pacientes, pero siempre haciendo hincapié que es algo transitorio, y la verdad que lo vemos en la práctica. Lo vemos que ya a las 2 semanas ya baja el 20%, y a los 3 meses es muy raro encontrar un paciente que todavía tenga incontinencia. Y en general se relacionan, como decíamos al principio, con pacientes con vejigas muy hiperactivas. Se asocia mayormente a una incontinencia más de urgencia que de esfuerzo. Es muy difícil en esta cirugía dañar el esfínter, ¿no? Para que haya una incontinencia definitiva.
I think that we all underestimate the load of incontinencia already before surgery. If you do a regular scan with ICIQ, for example, before surgery, in a patient group older than 70 years, you will find 30% with some degree of incontinence. So I always wonder, if I read papers, that there's no incontinence after surgery. Of course there's incontinence after surgery, because there was incontinence before surgery as well. And I think what we made in the last year, and we saw it very nicely, is that we know where to cut and what to preserve. So we basically do not mucosa sparing. That's what my new phrasing is. I do urethra sparing, or at least mucosa and submucosa sparing, because we are sparing the passive buffer of the closure of the membranous urethra. If we cut too deep, we cut out the lysosphincter, the longitudinal and the circular fiber, and they're the passive buffer. And this is the reason why people who are younger, and we don't respect that, will get continent, but old people with sarcopenia and with a lower chance of rehabilitation will stay incontinent. And if you look into them, it's like with an advanced band, you have the leak ventrally, because that is basically where it was lacking in the past. So, but all the discussions and life surgery, what we see nicely here today, and we will see it again in 2 weeks' time in TNT endourology with Cesare, that made the deal. We are doing urethral sparing these days, and there's not a problem with incontinence whatsoever today, because we know what to preserve. Basically, we do exactly, if you look to Jochen Wald's publication, that is basically dealing with radical prostatectomy, but it's the same thing. Urethral stump preparation into the prostate with radical prostatectomy with a robot, or in robotic adenomectomy inside, or from below, we do the same. We do an urethral stump, basically. We preserve the mucosa and the submucosa, and thereby we preserve the continence of patients, even old patients that will struggle otherwise with their continence. That was a very nice demonstration, and you're doing a thorough coagulation now before going for more oscillation, I guess.
So one of the points that we usually teach to the fellows during doing enucleation, that the most difficult point when you are trying to separate the adenoma from the bladder neck, because this is your blind spot. Like usually most of doing bipolar enucleation are happy all the time while rotating in the fossa. But when to come the stage that Dr. Rodrigo are doing now is that position is the most blind spot for you, because the adenoma is in front of you and the capsule is behind the adenoma, and you want to separate something from something that you cannot see. So either you go rotating from side to side like this is the attachment here on the right side that is keeping the adenoma from entering inside the bladder. And sometimes if you have even a bleeder, like if something that obstructs your vision, you could make a pressure over the irrigation. But I think when you are in your learning curve, the most difficult point is the point where you are trying to separate the deeper part of the adenoma at 6 and 5 and 7 o'clock. Exactly what we are at now, but the surgeon is doing very nicely, really, and smoothly. He is fantastic, really.
So this is why I advise at this point to push in the adenoma from ventral, because then it flips in and it shows the base, what we nicely see here. And then you can, you have a sight into your blind spot, because then you don't have to lift the adenoma anymore and prepare below it, but you have it toppled it in, and then you can find the last attachments. That's always, this is why, again, you need to free it completely ventrally to flip it in. And that's what we see here at the moment, very nicely by our surgeon, and very effectively, because then you can go along the mucosal rim as he's doing now and free the last attachments. They're very good.
Nice.
Maravilloso.
Thank you very much.
I would like to ask to international moderators if they find any difference regarding stress incontinence doing laser enucleation or bipolar enucleation.
If there was one, I would only do one. And as I'm still doing all, you see there's no difference, because I could not explain to my patients why I'm doing something which I'm not positive about. I think there is nothing, it's not the energy source again, it is the template. We know where to cut, either with bipolar, laser, in any laser, basically, and then we have the results. Again, it's the anatomy, like we had with ERBT before. It's always the anatomy and not the energy source. And of course, it's the surgeon and not the car. Yeah.
If you would like to have an ad for this point, like when going to have more stress incontinence with one of the energy, I think they are equal, as Professor Herrmann said, and only bipolar is going to be harmful if you are having a difficult plane and you cannot find your plane and you are using more mechanical pushes. So as a start for anyone who is in early learning curve, you have to have a mentor and have a cases with the smooth enucleation plane and not the fibrous one. Sometimes I know we can find cases where the capsule and the adenoma is difficult to separate. Even sometimes I may find an incidental discovery of a cancer prostate nodule when I find it's very hard to separate from the capsule and the adenoma. So be sure that you are not using strong pushes, you are just doing smooth as our surgeon here doing. And if you are using mechanical pushes or making an external curves with the screw, very much, this is not the case for bipolar, and maybe you have to think about another platform. But usually this is only what's going to happen in the small prostate, but in the larger one, you are never having a trouble finding you plane like over 80. It's the most nice plane you could find, and over 150 to 200, this is the playground for bipolar, because I going to say that you are having a shorter operative time if you are doing enucleation for a large prostate with a bipolar than laser, because we have a marvelous hemostasis. And as we see here, the surgeon have finished his surgery in 30 to 40 minutes, which is very fantastic for such size. But with the larger glands, he is going to have the same time, like 40 to 50 minutes, with one son, with a prostate like 150 grams, which is very, very nice.
It is so nice that even my son wants to see it, because he's popping in and out, as you have seen of the camera. I think he has now seen 100 transurethral enucleation. He's 10 years. I think he can do it in 2 years' time as well, if this was possible. But
we have a resident in your house.
When he's finished with medical school, I sent him to Egypt, to you, Mohammed, and then you can teach
You're most welcome.
I find the same. I find that the energy source is not the key point for continence. I think that preserve the strength that you imprint over the tissue is something really important. I make the same technique in HOLEP and in bipolar enucleation. The same. I do the same. I obtain the posterior plane. I release the sphincter, the upper plane, and the lateral plane, and the last step is release the median lobe. I find that the surgery is nicer. The bipolar is nice to see. People, anesthesiologists, people that are around us, find that the bipolar is a more nice surgery, because the plane maybe you can preserve better than with
Maybe I could interrupt you for a second. You left the bladder to be empty, right?
Well, what?
You left the bladder to be empty. You didn't keep it distended, right? Yes, the bladder is empty, so they are never they are going to do this while doing laser enucleation. Like they are keeping the bladder full all the time.
And this is why the anesthetists like bipolar surgery, because they don't see red. So that is stressing anesthetists and nurses. And we had the nice reference to the instrumentadores. It's muy importante. It's a team approach. And if your team gets stressed, then everything falls, especially in those patients where it bleeds. The irrigation is not recovered. And then you get the problems, especially in those patients where it bleeds. And so this is why everybody's super relaxed if they have good hemostasis. And as Mohammed says, if it doesn't translate into more irritation, which is debated, I don't see it, then it's a very nice hemostatic tool. And and now we have the morcellation. Which morcellator do you use? Do you use the drill cut or you use the wolf piranha? That is a drill cut, huh?
Federico, ¿qué morcelador estás usando?
Estamos usando un morcelador marca
I feel it's the stools one, I think.
de la nueva generación de morceladores oscilantes, la verdad. Por suerte no tuvimos la posibilidad de conocer los antiguos morceladores, que eran muy lentos. Nosotros ya comenzamos con este morcelador, la verdad que es muy efectivo. Acá nos puede contar Paola cómo están las revoluciones. Arrancamos bastante alto, como verán. Después, tal vez cuando la próstata se va haciendo más chiquita, podemos bajar un poco.
Hola, buenas tardes. ¿Me escuchan?
Sí, te escuchamos perfecto.
Sí, Paola.
Bien.
Yes,
Lo que estoy
yes.
coincidente con el cirujano es que la parte más áspera, digamos, de la cirugía es la parte de morcelación, donde el conjunto del circulante, instrumentador y cirujano tienen que tener muy presente que la vejiga no se venga, por lo tanto la irrigación tiene que ser a dos días de lavado, ¿sí? ¿sí? Con 4 bolsas de doble irrigación. Entonces, esto permite que la vejiga se mantenga extendida y no se colapse. Lo que decía el doctor Fossati es verdad. Estas brocas permiten, la verdad, que o evitan que uno pueda aspirar sin querer, digamos, la vejiga. Y solamente esa ventana que se ofrece entre la camisa interna y externa es la que aspira. Con anterioridad, otras brocas lo que hacían era la aspiración de panera frontal y la morcelación era de forma de guillotina. Por lo tanto, la vejiga, la verdad que a veces se veía bastante lacerada. No sé si no pudimos mostrar mucho el instrumental, no sé si algún instrumentador ahí de la sala tiene alguna pregunta que quiera hacer.
Pau,
Acá.
son 2
Yes,
camisas.
I think one of the things that we
Sí. Es una camisa externa, ¿sí?
Y una
La interna oscila sobre la interna. Es como dice el doctor Federico Fossati, comenzamos con unas revoluciones de 1500, de 1500, y a medida que se va morcelando el adenoma, se puede ir bajando esas revoluciones para evitar ese pivoteo del adenoma o que
Por
sea
ejemplo,
repelido.
Ahora.
Por ejemplo, ¿quieren por favor bajar un poquito las revoluciones?
Y la punta es cerrada, porque la camisa externa está...
What is your setting for the morcellation? Like, what is the RPM for morcellation?
Sí, así es. La
Rounds
punta
per
del
minute?
extremo de esta camisa
Yes, what
externa.
is your rounds per minute?
No. Tal vez esté un poco tapada.
¿Cuántas revoluciones per minuto
Empezamos con
está el
2500.
setting?
Ahora estamos
¿Cómo,
en 1800.
¿Cuántas rotaciones? ¿Cuántas rotaciones? 2000 or 1600? What is it?
En la oscilación. Así.
Federico, ¿en cuánto está seteado el morcelador ahora?
No, en
No, no.
5000, la oscilación en 5000. Las revoluciones.
5.500 las revoluciones,
5000.
comenzamos, ahora se bajó a 1800.
So usually
y
when
la
we have
oscilación está en 5000.
something with the adenoma, it's usually a problem from the suction and maybe
Yeah.
the blade, maybe something with the blade, but usually it is a suction or clogging in the tubes. So first we check our suction machine because sometimes it is not running very nice, and sometimes we may lower the RPMs around per minute of the, like what you did now exactly, like it was very fast. I think it was like 2,500. Now it is 1,800, something like this. So because sometimes the adenoma is more or less fibrous and not glandular. So the fibrous adenoma takes time in morcellation. The glandular adenoma takes less time, but it's going to give you a milky wash all the time, like you are having white inside the fossa, inside the bladder, because this is a lot of milk inside the glandular adenoma. But with the fibrous one, it is giving you a hard time with the morcellation. I think it's about the suction. Usually, the best morcellators that have the suction and reciprocation with the suction and the teeth that keeps the adenoma doesn't separate anytime. So when the adenoma is over the morcellator all the time, you have the best morcellation time, maybe reach up to 15 grams per minute or more. So morcellation and keeping the adenoma over the morcellator is the key of success of the morcellator.
Absolutely.
I'm sorry.
So we are almost done.
Can I make just one question or one advice? This is Martin Kanner from Germany. Hi, excellent surgery. I really like it. If you have some tissue there and it keeps escaping you, why don't you drag it back to the fossa where it cannot escape as much, and you may be faster in morcellating the last tissue in the fossa?
Sí, voy a intentar hacer eso ahora.
I must say, if you want to do something like that, what Dr. Kanner said is you need to have the bladder more full. You have to have more irrigation in, and I tend to morcellate with 40 to 50 centimeters, and then you see that this fossa collapses more. So I tried that after I've heard that everybody's trying to do that. But my fossa is collapsing, and I'm doing large prostate. So probably I have to put up the irrigation, which I don't want to do because most of my patients have a hypocontractile detrusor. So I want to avoid any further distensions of the detrusor. But again, everybody does what suits best and produces best results. And that is now he's following your suggestion, not mine. So Dr. Kanner won.
To be honest, like when your musculator is doing this, maybe you have to think about trying other musculators because it's about the musculator. It's not you. When you are trying to chase the small adenoma and it's not coming smoothly, it's about the musculator. So different one to choose between. Which one is going to make your musculation very fast and your life easier? So think about finding which one is the best because it is all about the musculator. It's not you at the end. It's a musculator. If doing good suction is going to make everything is very smooth. I know it's some devices are very expensive, but believe me, it's about the device. It's not the technique how you musculate or musculate inside the bladder or inside the fossa. It is the suction of the musculator and the musculator.
Yeah, that is paramount. I fully agree, and that was the biggest flaw in the first generation of this morcellator. The suction was poor, and also in the prior versions of the Wolf morcellator, where we sometimes used the side suction, the wall-mounted suction, in addition to what we had. So this looks very nice here. It's now completely done.
Yeah, it's very
Let's
nice
see
surgery.
whether he already introduces the catheter or goes in for another round of hemostasis.
Federico, la verdad, excelente
I'll do
cirugía.
that. I'll do that anytime. I go in and want to have a final look because I think that's the best invested 2 minutes. That's exactly like you say, you have the catheter in for 6 hours and no irrigation, or for 48 hours, something like that, basically. Yeah, he's doing it. Very good.
Excelente cirugía,
And I think that is
Federico.
what.
Muchas gracias.
Yeah.
Vamos a ir terminando. Damos un gran aplauso.
Muchas gracias.
Thank you.
Thank
Very
you
nice
so
surgery.
Thank you so much for the moderators. And